Moshi Moshi. Welcome to Evergood Podcast, where we talk about the future and also all things healthcare education innovation. I'm Kristy Bird McKeeve, and I am so excited today to have a friend, Dr. Debbie Lupeika, join us today. We're going to focus on the shift in culture that needs to happen when you're introducing new healthcare education. Like, let's just say it's a hospital and they're going to start taking medical students or residents. And what is it that we need to think about when we, uh, start bringing those learners into the environment? So, Dr. Lupeika and I am so excited to say, have been working together since 2019 in different capacities. And at that time, she was the program director for a family medicine residency at Shasta Community Health Clinic. I was founding Healthy Rural California. She's a board member of the North Valley Medical Association. I was the executive director. There's so much more. And I'm so excited to talk to you about that, Dr. Lupeika. Also, you are an associate dean at UC Davis School of Medicine. And
Yes.
in that role, it's a relatively new role. So I'm really looking forward to hearing what you've been up to in that role as well.
Yeah.
Because as faculty, you have that unique vision of being in the clinical environment and also being that educator. I also want to just mention you are family medicine doc, and you are currently working with the St. Elizabeth's in Red Bluff, correct?
Yes.
Okay.
And at the tribal clinic. Yeah.
Yeah. All right. What's it?
Mhm.
Is it Rolling Hills?
It's Rolling Hills. Yeah. It's the Rolling Hills Tribal Clinic. It's actually a rural tribal clinic with the Paskenta band of Milwaukee Indians. Yeah.
That's important work. Thank you so much for what you
Yeah.
do.
Thank you. Yeah. Appreciate that.
Okay, so your
Yeah.
full title as associate dean at UC Davis is actually longer than that.
It is, yeah. So, and that just started. First of all, thank you, Kristy. I really appreciate the opportunity to talk to you today. I know we've been trying to do this for a while, and I think it's super important work that you're doing. So I want to acknowledge that. And I can't believe it's been 7 years. When you said 2019, I was like, oh my goodness gracious, that is a long time.
Wait, I thought it was 6 years. You're right. We now turn the clock into
Seven.
2026.
Yeah. So no, I just want to say, Kristy, you're amazing. Everything you've done. I've been very lucky to work with you. So yes, thank you. And thank you for letting me talk.
Yeah.
Yeah. So just a little bit, do you want me to go into a little bit about me?
Yes, I would love that. Yeah.
Perfect. Okay. So as you said, I started as a program director. Actually, I started my story starts back from that. I did my residency program up here in Redding, California. So that's actually still where I live right now. And afterwards, I transitioned to an Indian health clinic for 10 years, Redding Ranch but I was a volunteer clinical faculty at UC Davis working with family medicine residents. Yeah. So I've actually been working as volunteer faculty for Davis and with UC Davis since 2000, which is a long time. So I did that, and then after about 10 years, I decided I really like teaching. So I shifted my practice to Shasta Community Health Center, which is a federally qualified health center here in Redding. And there was a new program. Again, this was a very long time ago called the Teaching Health Center Graduate Medical Education. So that had just started. It was in about year two or so. And so we decided, hey, why don't we try to start a program, partner with the program I went to here in Redding, which is the Mercy Redding Family Medicine Program, and start our own program at Shasta Community. So that's what we did. We started as a 222 program. I had my first residence in 2013, and then I gradually increased it to a 333, then a 444. So when I handed off the baton in 2024 to Dr. Mooneyham, we were up to a 444, which is super exciting. And we work very closely with the Mercy Reading program. And I actually still do teaching with them. I do lectures and some other integrative medicine with the Shasta Community Program. And so in July of 2024, I had the opportunity to join UC Davis full time. And so my big long title is UC Davis Associate Dean of Rural and Community Based Education. And so it's actually a new job through Davis. So that's been kind of exciting to expand and grow with UC Davis. So my big roles with UC Davis are site rotation, site management, because UC Davis has done expansion of their medical school, and we want rotation sites for medical students, not just in Sacramento, but in all the sites in Northern and Central California and the coast now, Santa Cruz, that
Yeah.
we want to train the doctors to come from those communities and then go back to those communities. So that's been kind of a fun, exciting part of my role is number one, expanding rotation sites, and number two, meeting with all those rotation sites. As a matter of fact, Reading Shasta Community Health Center, we have been part of the Rural Prime program at Davis since, oh, I would say 2013, 2012, around that time. We've had,
Right when it was starting, or
yeah,
soon thereafter, right? Yeah.
yeah, pretty much. And what I find is really amazing about that, because one of the things we're going to talk about later is why would you start, residency programs and have medical student rotations in your area? Well, you've probably heard about that physician shortage that's going on, especially up in my area here in Redding. It's hard to find doctors. And so a great way to get doctors is to get them from your community, help them into med school, get them in your residency, and then they'll stay. Dr. Mooneyham is my golden example of that. Dr. Mooneyham, who took my job as program director at Shasta, she grew up in Redding, Weaverville, actually, which seemed more rural than
Yeah.
Redding. So both, yeah. And then went to Davis Med School, rotated with us in Reading, went to the residency program, became faculty, and is now running the program at Shasta Community Health Center. So that is just a beautiful example of what can happen when you train your own. So that's part of my job at Davis. Another part of my job at Davis is I am the director of the UC Davis Family Medicine Residency Network. And there's actually 9 programs. Merced, Modesto, Stockton, Davis, Travis, Ukiah, 2 in Reading, and Chico. We actually just expanded to Chico. We're
Oh,
excited.
that
Yeah,
makes me happy.
that happened. Yeah, so that's thank you, Kristy. We've been talking about that for years. So I'm happy to say we added Chico in July 2025. And so with that, I am still working with the graduate medical education, family medicine programs. And most of these, well, all of these programs are training primary care doctors to serve their communities, and many in rural and underserved areas. In fact, I just did a site visit Friday in Ukiah. So we're trying to get some more medical student rotations there, and they have a residency program. So that's my Davis job, but then my clinical job is working for the tribal clinic that I was mentioning. And so I work 2 full days there in Red Bluff, and that is a tribal rural clinic. And I'm happy to say we're establishing medical student rotations there. And we've got some resident family medicine rotations as well. So that was a lot.
Well, but I know, and there's other roles. Like, are you still on the GME committee with Healthy Rural California?
Yes, yes,
Yeah,
I am. Mhm.
I love
Yeah,
it. You do so much.
Right?
But it's also very exciting to hear that that family medicine network is expanding because new programs are coming online and
Yeah.
um, hopefully well, it's not a UC Davis affiliate at this time, but the Dominican Hospital in Santa Cruz has it's their second year of their new family medicine residency. And then
Yeah.
they would be part of the Prime Central Coast program. So that might be a good one to absorb too. Yeah.
Absolutely. Yeah. I know their former program director, Dr. Walt Mills, who's an amazing man. Yeah. And then the other thing I should mention is that in UC Davis got a grant through CMSP to start an ACPC program, which is an accelerated medical student program. So basically, medical students, instead of 4 years in med school, they're 3 years. And that third year is spent in the partner institution or partner committee. I'm sorry, not committee, community. Right now, there's a partnership with Kaiser down in Sacramento. So now Davis has partnered with Shasta County, actually Shasta and Nevada County. So we're recruiting for students who are from Shasta County and Nevada County, and getting them into medical school this year, as in July 2026. And then they'll do their third year rotations up here in Shasta County. And then the hope is they end up matching in one of our residents and stay here. So that's a huge program. It's starting small and it's just going to get bigger.
So
Mhm.
one student for each of those counties is the goal right now.
Yep. And it's starting with primary care. So primary care is not just family medicine, it's family medicine, pediatrics, internal medicine,
And
OB, and then psychiatry. We're also going to say, yeah, you should know that because
I know,
Healthy
I'm so excited.
Rural, that's super exciting that Chico started their psychiatry program. So kudos to Kristy. You did a lot to get that up and running. That's huge. I mean, that's like the only psychiatry program for the most part up north here. Um,
Yeah,
so
and
that's
also in a rural community,
mhm,
or rural county, very few in the United States. So yeah, that was pretty cool to do. Um,
exactly.
we need more of them.
And this ACPC program will include psychiatry interested students as well. So, yeah, that's a big deal. And I think what a big deal for it is, again, if you can train them in your community and show them what a great community you have, and especially if they're from there, that hopefully they'll come back because the percentage, I don't have it off the top of my head, of doctor shortage up here, especially in Northern California and probably Central. Yeah, and Santa Cruz area is huge. So
Well,
yeah.
it has been Northern California and Redding in particular, Shasta County has been
Hmm.
deemed a specialty physician crisis area
Yep.
by Dr. Moo, the
Yeah,
public health officer. So I have been
exactly.
very focused on that as well in my new work that I'm doing. So yeah, I'm really hopeful that I can start a psychiatry residency in either Monterey, Santa Cruz area in the next 4 or 5 years. It's going to take a couple of steps to get there, but
Yeah.
we're on track for I think for that. And that's really why I wanted to focus our discussion today on that shift from really
Hmm.
teaching. And it's interesting because all of these different clinics that you're working with, that I've worked
Hmm.
with, yeah, some are teaching. Like I think
Yeah.
about a hospital in Chico where they have been partnered with Chico State Nursing, right? So they've been teaching nurses for since the beginning of this hospital. Um,
Yeah.
and the medical association had scholarships for nurses.
Hmm.
But that step into medical education is a big shift, a big
Hmm.
transition. And in order for it to be successful, there's some things that work better than other things.
Yeah.
And so I wanted to ask you about becoming the program director. So Shasta Community Health Clinic was
Mhm,
founded, and then you had a DIO. It became a sponsoring institution.
mhm,
You became the program director for this new family medicine residency.
mhm.
And that was what, 12 years ago? 10?
That was 2012 when we officially got our ACG
Okay.
accreditation. So it was a
I
while
think
ago.
it locked into my mind in like 2019, 2020 at that
Yeah,
point. So it's
yeah.
cool.
And
Okay.
then
So
2013, we had our first resident class start. Mhm.
so it was actually founded with the intent of becoming a teaching clinic.
Oh yeah, yeah. That's what we did. Yeah, there's, first of all, your sponsoring institution
Yeah.
needs to want to have a teaching program. So I think that's super important, and I'm sure we'll touch on that more. So Dean Germano, lots of people who are probably listening to this probably know Dean Germano. He is retired now, but amazing, amazing CEO, and he was the CEO of Shasta Community Health Center. And he really had that vision of we need to become a teaching health clinic because if you can, we need doctors, number one. And if you can train your own and stay here, it will just improve the healthcare. And it also attracts physicians because, a lot of times if you have teaching opportunities, people want to come there because they want to teach, they want to keep their knowledge up to date. So that's an important part is your sponsoring institution, whether it be an FQHC, a hospital, or whatever it is. They need to be on board. And I'm going to put kudos to Dean. Dean actually spoke in front of Congress, which is kind of a big deal.
What?
Yeah, you could probably Google and look
I
it
mean, I
up.
knew he was a badass, but wow. Okay.
He's like a beyond badass. So yeah. And he spoke, one of the things he spoke on, obviously, was federally qualified health centers, how important they are to the framework of the underserved and marginalized populations, but teaching health centers and residency programs. So yeah.
So that was at a time when, so the vocabulary is teaching hospitals is an indication that there are residency programs, right? And it's sort
Mhm.
of like this designation.
Yep.
You become a teaching hospital when the hospital becomes sponsoring institution or has residency
Mhm.
programs. At that time, though, the FQHCs were becoming more popular, but
Mhm.
not necessarily becoming sponsoring institutions to then have their own residency program. So he was really a leader in a movement across the
Mhm.
country then, or in that movement where the
Yeah.
FQHCs were becoming the safety nets in rural communities
Yeah.
and becoming more accredited by
Mhm.
ACGME to become
Yeah.
sponsoring institutions and have those. Yeah, that must have been a really exciting time to stand out there and talk about the importance of getting residency programs beyond a hospital. Because
Oh,
there's
totally.
not every community in this United States has a hospital.
Exactly. Yeah, and that was a big deal. And so, yeah, the funding is through HRSA, which is literally through Congress. Congress approves the Teaching Health Center funding. And so our health center, we've received the funding. And then we had a very nice, unique relationship, still do, with the hospital program. That's the one I was trained in here in Reading, and it is a family medicine program that has been going for over 50 years, which is pretty phenomenal. And
Yeah.
so that partnership where they have the hospital rotations, they're funded differently, they're funded through their hospital. We have a lot of the outpatient rotations, and we're funded through HRSA. And then we partner together. So the Shasta residents rotate in the hospital, the Mercy residents rotate in clinic. It's actually a beautiful partnership. And I know other places across the country have done that as well. And many clinics, and especially in California, have gone the teaching health center route. And when I first started, there was only like four of us. in
Get
California.
out.
Yeah, it was like, whoa, we are different, especially trying to advocate for funding and all that sort of stuff. And now I can't even tell you how many there are. I
Yeah.
think there might have been like 19, 20, something like that. So it's really grown. But I think the important thing was the leadership needs to be on board, and the leadership needs to understand. Because I remember talking in the beginning, going, if we have a student from Reading, goes to med school, say at Davis, rotates here, does our residency, stays. Like I remember telling them that. I'm like, that's going to take a long time, but mark my words, it's going to happen. And again, Dr. Mooneyham is my beautiful example. Look, see, it works. So yeah, it's important. And we talked earlier, like before we started, leadership. I mean, you always, you have a top down. I get it. That's super important. But really, when you're coming up with residency teaching, things like that, having some of that horizontal leadership discussions is important because your residency is going to have needs different than, say, the health center at the hospital. So you really need that partnership. And again, kudos to Dean Germano. He had a very horizontal leadership structure that really helps a lot.
And when was that building built, the new clinic, CSHC's clinic? I don't know. It's easier to say Shasta Community Health Clinic. But anyway,
It is, yeah,
um,
yeah.
because the building is set to be for teaching residents, right? There's certain things from AC requirements from
Yeah,
ACGME that you
yeah.
have to have dedicated space for those residents
Mhm.
to see their patients. And then it has to be in proximity so that the attendings can supervise. But really,
Yeah.
the whole building is so beautifully constructed to be a teaching clinic.
It really is. Yeah, I'm glad you asked that question. Now, when we started, um, it was a much smaller clinic. And so oh gosh, so in 2013, we kind of took over part of the family medicine department. And there's certain things you need to become a residency. And luckily, we had all those things. And then I can't remember what day, I want to say 2017 or 2018, somewhere around there. They built a beautiful tower there, and residency got the second floor, which
Yeah.
is amazing. So basically, I was able to help with the planning of that. Like, well, we need this, and we need this, and residents need this. And that was very exciting to just have our own floor. And then they built a third floor with a bunch of conference rooms, boardroom that allowed for the teaching classes that you need. So yeah, I mean and with if you're a teaching health center or if you're a teaching hospital, you do get, I mean, gets a little into the weeds, but you do get extra funding because you're teaching, right? Because it's recognized that teaching people takes a little time and effort. And so your reimbursement rates do go up. So,
That's so incredible. Yeah. Thank you for sharing that. I feel like um, with the work that I did in Chico with Healthy Rural California, becoming a non-clinic
mhm.
nonprofit,
Yeah, yeah.
uh, partnered with hospitals and clinics, of course, that there was a lot of concern by physicians, right? So the majority of physicians are in rural areas, just generally speaking. This isn't just about Chico, but that their advanced career, they're over 50 on average, or some such statistics that I haven't kept up with, but and then they've been in their clinics for a long time, and
Mhm.
the prospect of having to teach kind
Yeah.
of comes as like, well, that's an additional burden, as
Hmm.
opposed to you kind of learn pretty quickly how to absorb that extra work and then you just touched on the funding that's available, which is
Hmm.
fantastic. Um, it's a long game.
I
Uh,
guess.
so, but I was just talking with Dr. Hernandez the other
Mhm,
day because I'm involved with their foundation board now. And he started teaching the family medicine residents from Dominican. And
mhm.
it was a more, kind of a rough start first
Yeah.
year because it's new, right? Um,
Mhm.
but he's finding so much joy in teaching. And I think that's one of the things you can't really plan for. It is kind of an individual thing, but
Yeah.
transitioning from non-teaching to teaching as an organization and as an individual physician, it can actually bring a lot of joy to people.
Oh, definitely. I think one of the biggest things, I mean, I love teaching. That was why I went from the Indian Health Clinic to Shasta Community because I wanted to do more. I was doing teaching at the Indian Health Clinic and thought, wow, I could make a job of this. And so it was great. It really keeps you up to date. Not that you're not up to date, so don't take out like that. But, you've just got these enthusiastic people who are in parts of their career, either medical students or residents, that just keep you on your toes. And it's a good thing, and it keeps you definitely evidence-based and it inspires you a little bit because they're so excited and you're like, oh, all right, that's right. That's what that was like 25 years ago, and it
Right,
just,
connecting you
yeah,
back to the passion you had to become a doctor. Yeah.
yeah, yeah. And it's just very rewarding. And what sometimes becomes, it becomes so routine to us is like eye-opening to a student or a resident. And then you realize, wow, that's good. I just passed along some things that will help. And then ultimately, we always say this as program director, we're training these guys to take care of us. You realize that they're going to be taking care of us and our family members. And yeah, that like one of my faculty, his mother was being, her doctor was one of our residency graduates down in Marin. Like, she texted us and said, oh, or no, the mom texted us and said, why is this name familiar? And then we're like, oh, whoa, we trained her. And so the long story short, it just, I mean, you're training the next generation of physicians. That's a big deal. It's a huge deal and it's an honor. It really is. And I think most people are very excited and inspired by that.
I want to also touch on because this is, I hope many people listen to this and the
Mhm.
vocabulary around graduate medical education is so unique.
Yeah.
So Dean was the DIO, and as
Mhm.
CEO, he could be DIO, right? Like I
Yeah.
could have been
Mhm.
DIO for Healthy Rural California, but of course we had Dr. Ted Swerdling, who,
Yeah.
and now we have Dr. Harwood. So all wonderful, wonderful people. But Dean really had that understanding of the funding, the
Mhm.
advocacy that was needed, then also piecing together ACGME and being a partner with you as the program director leading that residency program. So
Mhm.
those are really important framework. It's an important framework to understand that it's the whole ecosystem of that institution. But you also mentioned Mercy Medical as the hospital for
Mhm.
inpatient. You had Shasta Community Health Clinic as the outpatient, that partnership. And Dr. Bland is still the program director of the family medicine residency. Uh,
He is, yeah. And talk about, kind of funny irony. I probably shouldn't do this. It might date both of us. But when I was a resident at Mercy, that was his first year as a faculty. So he was actually my faculty advisor way back when. And so then, yeah, we ended up being program directors together. And so again, I'm not from Reading. I'm from the Bay Area, actually. I grew up in Livermore, um, went to school at Berkeley. So my husband and I, he also went to Berkeley. We're like, oh, we're going back to the Bay Area. And then we ended up here in Reading and loved it. So it's not only trying to get the people who are from the area, but you want to attract people there and then they'll stay.
Yeah.
I think Dwayne is another one. Dr. Bland, he's from Washington, actually, and
Oh,
he did the exact same Mercy Reading residency. He was a 1-2, that was when they were a rural training tract of UC Davis. And
oh my God. I
so
forgot they started as that rural track.
they
Oh my gosh.
did. So
Yeah.
he actually did his first year at UC Davis, the Med Center, and then his next 2 years in Reading. And then suddenly was like, I like it here. I think he went and worked in Washington and then came back because he loved Reading. So that's another example of not just the people from the area, but you'll attract people to your area. And then I forget the statistic, but it's a pretty high statistic. A lot of people who graduate from residency end up practicing within a 50 to 100-mile radius of where they graduate because everybody. The specialists, who to refer to. So that's another bonus of having a residency program is people, you'll track people and they'll stay.
Well, the long, long, long game. Let's talk about Nicholas Germano.
Oh,
Dean Germano's
yeah,
son is now a
yeah.
physician at Mercy Medical. Yeah. And then
In
who's
Reading.
the young man from who was the resident who came from Altura and
Landon.
Landon?
Dr. Hagee. Yeah, here's another beautiful example. Dr. Hagee is from Alturas, Modoc County, way
Modoc
up
is
there.
like Modoc is the is frontier probably, not even rural.
It
Yeah.
it is, and he came to our residency program in Reading, and of course we wanted him to stay in Reading, but he realized, no, I need to go back to Alturas because that's where he has a big family there, and they have like 5 doctors out there. I mean, don't quote me on that number,
That's
but
high to me.
I, yeah, right. And so he's doing full spectrum family practice out in Alturas, Modoc County. And I'm just so proud of him. And he is still doing advocacy work because
See?
when he was I know, right? When he was a resident with me, I'm very involved with California Medical Association. That's how I met Kristy through our medical society. So I always bring residents on the board and to the meetings and to understand, hey, you have a say in policy, like real policy healthcare, not only in California, but if you join the AMA, you can go nationally. So I brought Landon to those meetings and he spoke up and he realized, wow, this is super important. So yeah, another example of an advocate who's working rural health in a very underserved part of our state, much needed.
Yeah. It is these are like the best examples of why establishing those medical education pathways locally or throughout when we think about Northern California and what
Yeah.
UC Davis has a priority to do, which is
Mhm.
really strengthening those medical education pathways throughout. Big credit too to everyone at UC Davis and Dr.
Yes.
Service, of course,
Mhm.
with the vision to really establish these regional branch campuses.
Mhm.
I know the terms are
Mhm.
not exactly the same, but sort of used in the same way, but sort of outside of UC Davis,
Mhm.
so that we can have more students from the area, more pathways for medical students to come to the area,
Mhm.
go through that journey in these local communities. So uh,
Yeah.
it's pretty exciting to see that and those resources really coming together. But it does take a local, I'm just reflecting on my current work in the Central Coast, which is it takes
Yeah.
that local effort in combination with UC Davis to really get things going. So anyway,
Yeah. Absolutely. And I'm glad you brought up some of those names because I'm going to bring up some names, more names from the past. So, UC Davis established their Rural Prime program. And I should know this off the top of my head because I have a slide on that, but That was many, many years ago. And Dr. Suzanne Edson Tong
Oh
and
yeah.
Dr. Tom Nesbitt.
Yeah.
Yeah, they were ones who, because Dr. Tom Nesbitt at Davis was doing telemed. That was like a big deal thing. And, Reading was one of the places Davis was doing telemed. And we're talking a long time ago. It's
Yeah,
not like
way
5 years ago.
before Zoom became a household name, right? It was like a
Yeah,
yeah.
15, 20, something like that.
Like
And
the
so,
internet was still sort of new.
yeah, right. And so Dr. Edson came to Reading and visited our clinic and said, yeah, we want to put students here. And we're like, we want students because, like you said, it takes that local. And part of why we were on the radar is Dr. Petty and Ron San both went to Davis Medical School. Their daughter was in the Rural Prime program, and they're like, we want our daughter, to have some experience up here. So that's, how some of that kind of starts. And then, like you said, Dr. Service saw that as a vision. And then we've got like five pathway programs through Davis. I'm talking Davis. You've got the Rural Prime. You've got the REACH program, which is focusing on students from like Stockton, Modesto, Merced. You've got the TEACH program, which is the urban underserved track. The tribal, there's a tribal
Yeah.
attracting Native American students and Central Coast. You could probably talk more on that one, but that's a newest one. And then, yeah, I just want to give a shout out to Dr. Mel Tranrena, who's the head of executive director of the Community Health, all those pathway programs, and Dr. Tanya Fancher. She's been working with her too. And those are both at Davis. So, yeah. And Dr. Mark Service, my boss. So, and Dr. Melody Howe. She's another important one. She's been working on these outside rotations for a very long time too. And that's why I work for Davis. There is a amazing team there that has the heart, the mission that they want to train people to go back to their community. We want to train the doctors that California needs, and each community needs different kinds of doctors. Alturas needs something different than Santa Cruz. So if you can train people to go to those communities, it's a win-win.
Yeah. Yeah, the Prime Central Coast is prioritizing speaking Spanish, but I think the exact, technical terminology is still being figured out as that application will open May 26th,
Yeah,
2026 for those new students. I have this cool little thing about the Tribal Health
yeah.
Post-Bac program too, and that is that in
Mhm.
Ukiah?
That's actually at Humboldt.
That's at
Yeah,
Humboldt, right? Okay.
yeah, Humboldt State, and that's the post-bac program where tribal students, if they get in and they hit a certain, there are certain standards that they get them into med school at Davis. So that's a big deal. And I know Davis is trying to work with other communities and colleges up here in the North State and probably Santa Cruz too to perhaps start some of their post-bac programs or other pathway programs. Because again, how do you got to find these students, and then once you get them, how do we get them into our school and then get them in the communities? And then it dovetails into residency programs,
Yeah.
because it's great if you have med school, but where are you going to train them? And if you train them outside of your community, are they going to come back? We hope they do, but that is a strong argument for developing residency programs. Definitely the various different ones, especially psych. Psych is very underserved right now.
Everywhere. Yeah. So that tribal health post-bac is at CSU Humboldt, correct?
Yeah,
There's no
yeah,
UC there. So
yeah. It's a,
wh-
the Cal
why
State.
why not think about post-bac at CSU Chico State?
Yep, or Simpson College in Reading. Yeah, these are great questions, right?
Yeah.
And we have that's another important one. It's called Avenue M.
Yes.
Avenue M is a partnership with a variety of community colleges and four-year colleges as well. Again, trying to identify local students who want to get into med school and then help them with some mentoring and resources. I mean, the students still need to do the work, they have to pass the classes, they have to take the test, you know, they got to do all that stuff. But if you can
Yeah.
get a little extra help and resources, that's good. And that's one of the things we're kind of working on right now. I'm sure Santa Cruz will be working on that as well. I've been focusing more on the North State with Chico and Shasta County. So we've been doing some talking with Simpson College, Shasta College, and Shasta County has Avenue and the students. And then Chico, I think we're trying to get some stuff going. And then you have Butte College as well associated with Chico. So
Yeah, and I will say a shout out to Healthy Rural California doing the Med Ed Club. So
yeah,
focusing on middle to high school and prepping those students and then connecting them with those other pathways as well. Yeah, I am working on that a little bit with the folks in the Central Coast where there are some programs, some really good community colleges as well, and just trying to strengthen that a little bit. Of course, UC Santa Cruz has been a leader and CSU Monterey Bay, so it's not like really much that needs to be done other than connecting people.
yeah,
This recording, this podcast is going to go into the monthly e-newsletter that I've created with their medical association and their foundation to just talk about that faculty development. And this is why I wanted to look at that culture shift that's needed
yeah.
because there is no sponsoring institution in the Central Coast right now.
Hmm.
There are two residency programs that are one is very old, one is new.
Yeah.
Their sponsoring institutions are not in the Central Coast, and so it's
Hmm.
kind of exciting to consider
Hmm.
that, but then also like there's just so many questions. I think another pressure point with um, uh, community, like with clinics and hospitals taking on medical students and residents is a new thing, is that there's so much pressure from other healthcare workforce education pathways that
Hmm.
like it's a friend of mine who's now running or part of the FQHC clinic in Southern
Hmm.
California. I think they have like nine clinics. I forgot what she just told me, but she was like, how do you balance between, social workers need to have an enormous amount of time in the clinics in order to get their degree. Uh,
Yeah.
the radiology techs, I'm going to give a shout out to my friend Lisa, who was working with me at Healthy Rural California and
Hmm.
going for her radiology tech degree and like or certificate and was just working her butt off to meet
Hmm.
the requirements of that
Yeah.
radiology tech degree and then not getting hired because she didn't have enough experience
Oh,
and
that's
having
too
to get that experience and went to Oregon and got hired immediately. So apparently
bad.
California's requirements are a little bit too tough for radiology techs. But anyway,
Gotcha.
there's so many nurses, right? There's so
Hmm.
much clinical experience required in the healthcare education pathways. And then how does one clinic prioritize medical education or still help all you can't have all the students running the learners running the clinic. You have to have that balance. And
Yeah.
I just do you have a I'm sorry to spring that one on you, but I
Oh,
just
that's good. Hmm.
wanted to talk about it.
Yeah, no, that's a great question. And that's something that you definitely start running into because, clinics are like, whoa, 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 we've got MAs and nurses and this and that. And, how can we have medical students and residents? And the answer I would give is you can have all of the above and they can all learn together. And I mean, at academic hospitals, the classic hierarchy is you've got like a team of like 15 people following the attending around. That's probably not realistic in small community settings, but you're not looking to have 40 people in your clinic. It's a much smaller number. And what we found, at least when I was teaching, when I'm rounding in the hospital up here in Reading, if I've got, two residents and a med student or two, it's fine. It actually kind of elevates the team because the med students can look stuff up for you, or the residents can
Right.
teach and present things. You can get
And
a
when
pretty
you teach, you learn.
exactly. You can
Yeah,
get a big, robust discussion, so it doesn't all fall onto the attending. I mean, you're leading the team per se, but you're also teaching. At Shasta Community, we always had like MAs or nurses or scribes who were in training, and they were with us. They're following us. Um, it just you probably can't have your trainee nurse, MA, scribe, resident, medical student all at the same team at the same attending. That might be a bit much. So there is some scheduling you need to do. But I think it just elevates everybody. And what was nice is when you put people in those teaching roles, just like you said, you have to learn because you can't teach if you don't know the subject. So it makes you understand the subject a bit better as well. And I did find that our scribes and our nurses, they were kind of excited. In fact, at Rolling Hills, we don't. That's my clinic. I had a pre-med student who was following me, and I was like, "Hey, why don't you follow some of the MAs?" And I told the MAs, "Why don't you teach them what you guys know? Because she's pre-med and she needs to know everything about everything." And my MAs were so excited. They were like, "That was so much fun. I didn't know how much I knew." And I find that out a lot. Like students will say that, residents will say that, like, I didn't realize how much I knew. And it's like, you do know a lot, and sharing. I mean, what is that? Pass it forward. I
yeah,
think, yeah, did I say that right? There's also, help the next person in line, you
yeah.
know.
Yeah. You touched on something that I have heard as well, that it's not just the doctor teaching the medical student or the resident. Like, well, residency is it has its own teaching and milestones and everything for the learner, but everybody has
Mhm.
something to teach the
Oh, yeah.
physicians who are just starting out. And like that was such a beautiful way to describe it. Thank you for that.
Yeah. Well, I mean, come on. I remember when I was an intern. I was an intern. It's like my first week or two, and that was paper. You'd write your paper order,
Yep, yep.
and then you'd get a phone call. You get the text, and then you'd have to call. And the pharmacist would be like, Dr. Lupeika, you wrote this. Do you think you meant this maybe? And I'm like, maybe, the point being is the pharmacist would then teach me and be like, okay, well, when you're doing this, do this. So, yeah, absolutely. You need attending physicians, but you also need the nurse who's been on labor and delivery for 20 years to teach you how to do that, OB exam, or the front desk person who teaches you how to order things. I mean, it's a whole system. Everybody's
Yeah.
teaching everybody else.
And
Mhm.
learning the system,
Yeah.
learning how all those pieces fit together. The one thing I heard when I used to work at UC Davis was how siloed the education pathways are. And
Mhm.
then you're supposed to work together in a clinic and know what the different roles are. And,
Mhm.
so yeah, the being able to learn all of that before becoming an independent practitioner is really cool, really good stuff.
It's it's huge. Yeah. And I think that's where some of the smaller settings and academic medicine too, they can do it too. But you have those interprofessional teams where you're rounding in the hospital, the pharmacist talks, the nurse starts, the Like you need that because it you need all those perspectives. So anyway.
Touching on that too, I think the smaller clinics probably think, oh, we don't have any value to add to the learners,
Mhm,
especially if they haven't had rotations or, anything formalized. And yet they do. I think you mentioned that with our friend in Alturas, who is a
mhm,
full spectrum family medicine doctor now, and some of those clinics you get to really see the full breadth of care, whereas when you're in a larger institution, maybe it gets a little bit siloed. And so I think the small clinics
mhm,
have a lot to offer. They can give more insight. They could probably walk into the CEO's office and sit down and have a cup of
mhm.
coffee together when you can't really do that in a bigger institution.
Yeah, yeah, no, definitely true. Yeah, and again, the bigger I work for Davis, right? It's a big one. It's got a lot of resources, got a lot of amazing teaching. It has, I mean, like Reading, that was our referral center, right? We didn't have a pediatric endocrinologist, so we had to send them to Davis, and but they would do telemedicine, so my patients could still get that big academic center resource, even though we're here. And then, yeah, you're it some places. And so you got to learn how to do these things. And there's always stuff that, I mean, I've been practicing a long time, 26, 7, 8 years. And there's still stuff that comes in my clinic that I'm like, wow, all right. And, I'll call my specialist friends and they're like, I've never seen that either. I'm like, great. What do I do with this? So we're always learning. So I think that's the important part.
Yeah. Well, I don't want to take up too much of your time. Was there anything else that you wanted to be sure to share, or and we can always do another podcast recording. We wanted to talk about nutrition at one point too.
At some point, yeah, yeah, because that's huge, right? That's a big thing in LCME medical school. There's
Yeah.
some new nutritional competencies, and it's probably going to hit residency too. Yeah, that's we can absolutely do that. But yeah, I think the I don't know, take home points would be for culture shifts for teaching. Number one, have your sponsoring institution, your C-suite, your leadership, whatever it's called in your organization, all be on the same page because it does take some support to get this going. And I would definitely remind them that it having a teaching, it attracts physicians, MAs, it attracts people.
Yeah.
So your clinic is going to get more providers because of that. And it's also an opportunity to train your own, right? That's the exciting part. And, Dr. Minningham was my lovely example. But the point being, it works. I mean, that's huge. So I go to, in fact, just at Ukiah, they told me a person who used to work at their clinic is now in med school at Davis. And they're like, hey, we'd love her to do rotations here. And I'm like, well, let's try to figure out how to make that happen because, hopefully that person will come back to Ukiah and be a physician there. That's kind of the goal. Hmm.
I forgot, and we should mention this, that we're partnering right now with Dr. Danuka on a GI fellowship.
Yeah. Hmm.
These are very tough to do. It's funny to actually say. I think the psychiatry residency is a lot easier than a GI fellowship, right? Like who would have thought that? But in terms of
Yeah.
what a community has,
Hmm.
and the requirements of ACGME accredited sponsoring institution with an IM
Yeah.
residency is therefore the base foundation of a GI fellowship. Anyway,
Yeah.
so all really great stuff, and
Yeah.
the other medical school branch campus discussions that we have also really great. But I was just one question left.
Okay.
How close is Rolling Hills to St. E's?
How close is it?
Yeah.
It's right there. Like there's okay, when you drive in, so
Yeah.
St. E's is right there. There's like a little road around St. E's in Red Bluff, and there's a bunch of clinics.
Yeah.
It's one of those clinics. So literally at lunch, I walk across the street, have lunch, and come back. So I mean the hospital's right there. And there's imaging and surgeon, like a general surgeon, an orthopedic surgeon, tribal clinic, a women's health, an OB clinic, an urgent care. I'm just trying to think all the clinics because I walk by them all. Lassen Medical, which is like a primary care clinic. Oh yeah, we're all like right there. It's right next door.
Why don't we look at one of those becoming a sponsoring institution? I think that's what you emailed me about this, I think
I did. Yeah.
very recently, and I
Mhm.
was like, huh, what
Yeah.
that could be really interesting.
Yeah, well, there's no GI doctors in Red Bluff, so I'm sure St. Elizabeth's would love that. So yeah, St. Elizabeth's is associated with Common Spirit, which is mercy, and so there's St. Elizabeth's, there's Mercy Reading, and there's Mercy Mount Shasta. So they're all. So I think I don't know if we're.
Rolling Hills could become the sponsoring institution with IM in coordination with St. E's. And then our Dr. Danuka is just not that far away in Reading
Mhm.
with
Yeah,
Reading and
we might want to hit pause. That's probably a conversation to,
yeah,
yeah.
yeah. No, I know, but this is just again like
Hmm.
I really didn't have that visual. And I've been to Red Bluff a couple of times, but I didn't have that visual in my mind because that's pretty cool.
Oh yeah, there's clinics all around. And as you're driving, you'd be driving north. I mean, Fanny's is right outside the freeway. Like it's one exit. But if you're driving south and you miss that exit, you go a very long time before the next exit.
I'm
'Cause I've
familiar
done
with
that
that.
before. I did it once and then I was like, doggone it. I think it's like Corning is the next exit, which is kind of far. So,
Well, thank
but
you for all of this. And I think we should schedule another podcast because I really am intrigued about the nutrition question too.
yeah, yeah.
Um,
Mhm.
all of the things that we're working on. So thank you so much for your time
Yeah,
and thank you for the words of encouragement for, um, I'm thinking right now about the folks that I'm working with in the Central Coast, but
yeah, yeah.
this is a broader discussion for anyone in the United States that's going, gosh, we understand the need for developing medical education pathways,
Mhm.
but it just seems so daunting. You've given words of
Yeah.
inspiration, so thank you for
Well, thank you. And thank you for all you do, Kristy. You're amazing. You helped start that residency program, the psych and family and Chico. And yeah, no, you're great. And thank you. I appreciate that you asked me. I'm obviously happy to talk. I talk a lot. Didn't realize I had so much to say, but yeah, I'm happy to talk anytime. So thank you. And thank you for what you're doing. And we're really excited at Davis to be developing the Central Coast Prime. That's huge, like a big deal. So
it
thank
is.
you.
It's so exciting. I also have to say, I'm working with Physicians for Healthy California too with their GME startup solutions, and that's been fun to help figure that out as well. So lots
Oh,
of
definitely. Yeah, I love the MedEd Club. They just got funding for Branch Campus. And, there's a lot going on in Shasta County, too. We're going to have that third year medical students coming up here. And, there's a lot of excitement happening in North State and Central and Stockton, Merced, too. But,
absolutely.
I am a little biased. I still live in Reading. So it's all good. So, but
All
thank you.
good. It's an and equation, right? We need
It
all
is.
of it. We need every
Um,
every pocket of the, Central Valley, Central Coast, North Coast. I mean, like it's just
mhm.
pockets of California. So I'm happy
Yeah.
we're all still working together in these ways.
Yeah, me too. As one of my mentors said, it's all connected. So,
It's all connected.
yep. All right. Well, thanks, Kristy.
Yeah.
Have a good rest of your day.
Lost my sense of humor, I've climbed down too far to now. Hovercrafts, blow up kayaks would have helped with angry toes, but it gave mashed potatoes. Take that meatloaf back. Hi. Birthday dehydrated cake and box of wine so nice with clean dark hair.